The prevalence of pediatric inflammatory bowel disease, PIBD, particularly Crohn's disease, has been steadily rising. Most cases occur in older children and adolescents. While the pathogenesis remains incompletely understood, the widely accepted model suggests that genetically susceptible individuals, when exposed to environmental triggers such as westernized diets, gut microbiota alterations, or infections, may develop disease through epigenetic mechanisms. Paneth cells, known for producing antimicrobial peptides like alpha defensins, help regulate gut microbiota. In individuals with NOD2 gene mutations, alpha defensin secretion is markedly reduced, compromising this microbial balance and predisposing to Crohn's disease. Epidemiologic studies show that infants exposed to anti-anaerobic antibiotics before the age of 1 have an increased risk of developing IBD, with a hazard ratio of 5.51, likely due to disruption of gut microbiota development. Experimental studies in zebrafish and BALB/c mice demonstrate that a high cholesterol diet leads to increased intestinal infiltration by myeloid cells and macrophages, as well as elevated IL-1 beta. These findings support the role of inflammasome activation and caspase-1 in linking dietary factors with PIBD pathogenesis. Diagnosis is histological with hallmark features such as neutrophilic infiltration of cryptitis, crypt abscesses, and ulceration indicating acute inflammation. Chronic changes include basal plasmatosis and crypt architectural distortion. Non-caseating granulomas and transmural inflammation are more specific to Crohn's disease, while ulcerative colitis is typically confined to the mucosa of the colon. Beyond antibiotics and diet, other proposed risk factors for PIBD include smoking, air pollution, psychosocial stress, and depression. Endoscopic features of Crohn's disease often reveal linear or serpiginous ulcers, skip lesions, luminal strictures, and perianal disease, for example, fistulas or abscesses. The Paris classification, an adaptation of the Montreal classification, was introduced in 2011 to address pediatric-specific features, including small bowel involvement and growth delay. Height for age Z-scores, specifically a deviation greater than 2.0 from the mid-parental height and greater than 1.0 from pre-illness height, are used to assess growth impairment. Mueller et al. Reported that ileocolonic involvement with luminal stricture is the most common Crohn's phenotype, and perianal disease occurs in approximately 15% of children. Clinical markers associated with a poor prognosis and possible indications for early biologic therapy include severe disease behavior, perianal complications, growth failure, and deep mucosal ulceration. At our pediatric GI clinic, disease activity is commonly assessed using the Pediatric Crohn's Disease Activity Index, PCDIA, with scores less than 10 considered clinical remission. However, clinical remission alone may not reflect true disease quiescence, as mucosal inflammation may persist and progress silently, leading to complications requiring surgery and risking short bowel syndrome. Therefore, treatment goals have shifted towards achieving transmural and histological healing as recommended in the STRIDE guidelines by tight controlling and monitoring diseases. To accomplish this, close monitoring using both fecal calprotectin and endoscopic evaluations is essential. In Crohn's disease, imaging modalities such as MR enterography or intestinal ultrasound can help assess transmural healing. Multiple studies support the association between mucosal and histological healing and improved long-term outcomes. The Crohn's Disease Endoscopic Index of Severity, CDIES, remains a validated scoring tool, although it requires segmentation adjustments and is complicated. The simple endoscopic score for Crohn's disease, or SECSD, offers a more practical alternative, grading 5 intestinal segments with a maximum total score of 60. Scores less than 2 indicate endoscopic remission. In ulcerative colitis, the Mayo endoscopic score is often used to classify mucosal findings. A score of 0, which indicates normal mucosa, reflects endoscopic healing. Other findings, such as erythema, friability, erosions, spontaneous bleeding, and ulceration, correlate with increasing severity. Pseudopolyps may also be seen.